So here are just a couple of reminders. Make sure that your microphone is off and to please keep your camera off just for sake of internet connection. Please feel free to ask questions in the chat. There's going to be plenty of time for each speaker to answer your questions. Again, we're recording this meeting, and then we will answer what we can and post what we don't get to on our webpage. So here's our land acknowledgement. Please give a thumbs up emoji if you can hear it. You should be able to. So thank you. Go ahead, Kendra.
Arti swatwiftud atish poyalapaj, a slathasil, altidisha to alturi tuha.
It is the land right here that the Puyallup people have lived on since the beginning.
This
right here is where we are in the world, our homelands.
Uyayushas atiswatufted atishu ishachas. Ukachachas tisbadadachas. Uoch twatichalat atiswatufted atispoyalapabs.
We work on our ancestral lands. We raise our children who go to school on the land of the Puyallup people.
Ohegwed chas ti shwananam tliti, ohashitab ti pasted okweredu.
We acknowledge that the Medicine Creek Treaty was signed for the whites to take our land for their benefit.
Ohashitab chas ati shwananam tliti ati swatwiftud chas. Otsuti pasted squat lup swatwiftud lup.
Land was assigned to our people. The Caucasians said, "This is your land," and they took that land from us too.
Our land was stolen from us. Treaties were broken.
But we are still here today.
Our people forage for food and materials, we pick berries, we canoe, we practice our traditional ways, and we speak Twelshutsi.
Just as our ancestors did.
We are finished.
Thank you, everyone. All right, so our first speaker today is Dr. Liesl Sapico. I apologize for that. Dr. Liesl Sapico. Liesl is an obstetrician gynecologist with Virginia Mason Franciscan Health. She's been with VMFH since 2014. She originally was based at St. Joseph Medical Center in Tacoma, Washington. And when the opportunity came to open a new Virginia Mason Franciscan Health OBGYN practice and new birth center at Virginia Mason Medical Center in downtown Seattle, she quickly realized this as an once-in-a-lifetime opportunity to help create an OBGYN practice and birth center that is both innovative and patient-centered. While still in Tacoma, Liesl had already begun developing an interest in perinatal mood and anxiety disorders and had joined what is now called the Perinatal Emotional Health Committee in Pierce County. She also trained in centering pregnancy and led a high-risk centering group in Tacoma. Yes, in Tacoma. When she relocated to Seattle, she continued on her path to learning more about perinatal mood and anxiety disorders by getting her certificate in perinatal mental health, psychopharmacology through Postpartum Support International, and underwent the training for group peer support through Perinatal Support Washington. She also received a master's degree from Gonzaga University in organizational leadership, where her capstone project was on developing a postpartum program that focuses on postpartum mood and anxiety disorders, hypertensive disorders in pregnancy, and gestational diabetes. This capstone has grown into the Postpartum Wellness and Recovery Program, or POWER program, which recently rolled out phase 1 of the pilot in October at VMMC. As an OBGYN, she has seen firsthand the challenges new patients face with having a new baby and also managing PMADs, and the kind of support parents need to navigate what can be both challenging and scary times for parents. Away from work, Liesel is a dedicated dog mom to her spoiled German Shepherd Milo and his equally spoiled sister Sadie. I feel that. Her newest addiction is all things plant related, and you can typically find her in stores scoring for a good deal on a unique plant or obsessing over the health of her current plant babies. Wow, I feel like we might be the same person in that aspect. So thank you so much, Dr. Sapico. Please feel free and take it away.
So hello, it's actually Lizelle, but that's okay. Everybody gets it wrong the first time, but I'm gonna go ahead and turn off my video because it makes me nervous when I see people, so I hope you guys don't mind. And so thank you for the introduction. So but we'll go ahead and start talking about the Postpartum Wellness and Recovery Program, how it started and where we're going towards. So next slide, please. So just as a quick overview, we're going to do the patient's voice. It is a video. I think that when we talk about morbidity and mortality in the postpartum period, I think that getting a viewpoint of a patient is incredibly important. I think it grounds us and brings us back to why we do the work that we do. We'll talk a little bit about maternal morbidity and mortality, what maternal care continuum is like, what the POWER program is, and then we'll end again with the patient's voice and then a Q&A at the end. Next slide, please.
We are in business. Thanks for everyone's patience.
Thank you.
There's no mom like you, and in this picture I kind of see her when she was in the hospital.
She loved motherhood, and she and Sophie were extremely bonded. I mean, everything that Joan did, she had Sophie with her, and Sophie slept with us for the first 2 years. I never really thought I'd be a father. It's been quite the experience, quite the ride. It's a learning curve, but I love it. They were kind of telling us, you know, she's severe preeclampsia, but don't worry, because the cure for preeclampsia is delivery. So we're going to manage this pregnancy a little bit more. Her blood pressure is at 172/95. It's very elevated. There was not a whole lot of in-depth discussions around preeclampsia and what that could be. Everything was, if the baby's delivered, everything's going to be fine, because that's the cure for it. 48 hours later, after her being admitted, they, again, did a C-section on her. You know, at that point, it's like the baby's out, your wife's going to be fine. She was not discharged by the high-risk doctor that had admitted her to the hospital. She was discharged by the third doctor, if you will. There was no discussion with the high-risk doctor about any of this. And she was sent home. There was no mention of any complications from preeclampsia after the birth. Here we are 48 hours after delivery. She's had multiple pregnancies. She's over 42. She's diabetic. She'd had in vitro fertilization. She'd had miscarriage. She'd had the issues with potassium. She had some family history behind her. So there were probably 7 or 8 red flags that should have been considered. Over the course of the next 48 hours, she was experiencing difficulties with breathing, which we kind of passed off to, you know, she'd put on a lot of weight. She'd had the C-section. Her breasts were swollen from lactation. We were just looking at all these signs as like, it's just normal because you've been slightly eviscerated and everything else. So what we didn't know is that she was having issues. We were discharged on Sunday. That Tuesday, I had gone back to work in the morning. She had gone to the doctor with her brother, with Sophie. She was experiencing a lot of shortness of breath at that point. So we just basically he got her back home and put her to rest. And I came home from work that afternoon. I'm exhausted, so I go to bed at around 11, and she wakes me up at about 12:15, and she's like, I need your help. And I'm like, well, what's the problem? She goes, I can't breathe. And to me, it looked like she's hyperventilating. She's just getting very anxious, and she's getting very excited, you know? She hadn't had a lot of sleep. She was having a lot of issues, and I just was like, she's hyperventilating. So my job is to calm her down. So there's no warning bells going off in my head at this point. I'm not thinking I need to call 911 immediately. I'm not thinking I need to put her in the car and take her to the hospital, which is literally 5-7 minutes from here. She is devolving rapidly in front of me. She's, you know, asking for cups of water. She's asking for cups of ice, and she's dumping it over her head. I mean, her arms are just, you know, this. At that point, I'm like, okay, I don't know what's going on. So I called 911. And in the span of That call to them arriving here was probably about 7 minutes. She went from standing to sitting to laying on the floor to not breathing. The last thing she said to me was, "I love you." They basically put her on the board, took her out of the house, and kept working on her. It took them 25 minutes to establish a pulse. Over the course of 2.5 weeks, that's how long she stayed with us. I think I said, "I'm sorry" to you every single day. You trust what the experts are telling you. You trust that the people you're dealing with are telling you everything you need to know. You trust that they're being honest with you. If there was something to be concerned with after the delivery, because the cure for preeclampsia is delivery, you're out of the woods at this point, and nobody's telling me otherwise at that point. So everything that happened after it, you blame yourself for because you're not paying attention. Should I have gone on and looked up preeclampsia on the web? Because, hey, you know, the internet's a great thing now. Should I have looked it up and been aware of it? Would have, should have, could have thing. Everybody says, well, don't blame yourself, but, you know, that's easy to say. It's another thing to be the individual that was the one witnessing everything that happened here and supposed to be the protector of the family. Why not be taught about help? Why not be taught about some of the risks that are associated with what you're currently experiencing? You know, a cancer patient certainly knows what their risks are when they start taking chemotherapy. They know what they're in for in the long haul. Preeclampsia, you know, if it's been debunked that delivery is the cure, be honest about it, you know? You know, the ending doesn't change. There's never a happy moment that comes from it. But if somebody else can live because they've heard this story and understands, you know, what preeclampsia is and takes it a little bit more seriously when talking to their patients, or as a patient, they understand what the symptoms are and they're not afraid to speak up, then something comes from this. And that's what I hope.
So, there we go. I, you know, obviously have given this presentation before, and I think that every time I watch this video, it still gives me the goosebumps because of all the different times that there were misses in the care of this person. And so, again, you know, the reason why the patient's voice is so important is because we have, again, to ground ourselves and to realize who it is that we are taking care of, and that it's not just patients, it's families whose lives can be changed and destroyed by, you know, us not doing the right thing at the right time. And obviously, I think, you know, being in the world of, you know, pregnancy, I think all of us are very aware of what's been going on in the news lately. This one from the Associated Press was just taken, I just found that last week. Maternal morbidity and mortality in the US is the highest out of all of the developed nations. We are the only country, rather than seeing an improvement, have actually continued to see a decline. And what's really sad is that the majority of these deaths are actually preventable. For those that have preeclampsia during pregnancy or postpartum, 65% of those deaths are actually preventable. And so it really, you know, begs the question, what is it that we're not doing right, and what is it that we can do to help? When I looked at the Washington State maternal morbidity report from 2014 to 2016, 66% of the deaths during that time period were actually preventable. Next slide, please. So I'm not sure if you guys can see this very well, but number one, I really like the colors, but then I realized that each of those dots actually signifies a death. This is from the CDC, and each dot represents one death, and then there on the side it shows the reason for behind the death, and this is only for 36 states. So if you really think about, you know, what this chart would actually look like if we included the whole country, I think that we would all agree that the death rate for women and birthing individuals, it's too high. And for a developed country such as ours, where we actually have the highest number in healthcare spending, what we have here is really, you know, a sad it's a sad picture for how we treat our parents and birthing individuals. Next slide, please. This actually breaks down maternal morbidity and mortality by race, and Black women and birthing individuals have the highest rate of mortality. And this is not even affected by socioeconomic factors. So if we had a college college educated, private insured, best hospital out there, if this patient is Black, her likelihood of death is much higher than her other counterparts. Next slide, please. And so again, this is just another breakdown of how the US in comparison to other industrialized countries does with maternal mortality. So obviously we are almost 24 deaths per 100,000 lives births. France is far away at 8.7. So again, why is the US not only not improving, but actually getting worse? This other chart really shows what the maternal mortality rates are based by state. And I think that, if you also keep track of the news, the South has been having a lot of issues with maternal morbidity and mortality. And this chart really shows how high the death rate is there for women and birthing individuals. Next slide, please. So what can we do? And so this comes from the Action Plan to Improve Maternal Health in America. So communities can, number one, create social and physical environments that promote good health, provide breastfeeding support at the individual and community level, strengthen perinatal regionalization and quality improvement initiatives. So really what regionalization means is empowering and strengthening our hospitals to give the best care within their means, and that if they're not able to have access to those higher risk hospitals for the patients that they serve. And so it's really about everyone doing their best at what they're good at. Promoting community-driven initiatives and workforce development, ensure a broad set of options for women to access quality health care. And so this could be not just delivering hospital, it could be at a birthing center, it could be at home. But we want women to have, and birthing individuals to really have the option to get the kind of the care that they need, and to ensure that that care is high quality. Support evidence-based programs to address health risks before, during, and after pregnancy. Improve the quality and availability of data on maternal morbidity and mortality. And as you saw in that previous slide, there were a few states that actually did not provide their data. And I think that if we have that, then we have obviously more information and data to go on to try and decide what really is going on and how can we address and fix that. What can we do as healthcare professionals? We can ensure quality preventive healthcare for all birthing people and families. We can address disparities such as racial, socioeconomic, geographic, and age, and provide culturally appropriate care in clinical practices. We can help patients to manage chronic conditions, communicate with women and birthing people about their pregnancy, facilitate timely recognition and intervention for early warning signs during and up to 1 year after pregnancy, improve healthcare services beyond the postpartum period, participate in quality improvement and safety initiatives to improve care. And so the reason why those two are highlighted is because this is my segue into the POWER program. Next slide, please. And so, just to make sure that all of us are on the same page, what exactly is the fourth trimester? And so that is defined as the first 12 weeks after delivery. It's a critical period where parents are adapting to multiple physical, social, and psychological changes, along with having to manage pre-existing health and social issues. I always, when I talk to my patients, I always talk about, what's your postpartum plan like? I think everybody thinks that, being pregnant with a baby and delivering it, once you deliver your baby, everything is good. But what we can all understand, whether or not we've had children ourselves or have been witness to people who are close to us have children, is that bringing a newborn home is a complete different set of challenges. And when you add on to that other comorbids such as hypertension or anxiety or depression, that postpartum period is probably even more important than the pregnancy itself. Oh, next slide, please. So what does prenatal and postnatal care look like? And so this is just kind of this nice continuum. For those who aren't familiar with prenatal care, we see pregnant patients a lot. During the first 2 trimesters, we see them every 4 weeks. In my practice, from 30 to 36 weeks, it's every 2 weeks. And then from 36 to delivery, it's every week. Then they go to the hospital, and then we have this arbitrary chosen, all right, well, had the baby, we'll see you back in 6 weeks. But what we need to understand is, number one 6-week visit is not enough. The major risks of pregnancy-related conditions happens actually during this first 6 weeks after delivery. Half of postpartum strokes actually occur within 10 days of discharge. Those who have hypertension in pregnancy, their blood pressures typically go up between days 3 and 7. 20% of undesired weaning occurs by 6 weeks postpartum. Then we also have postpartum depression and anxiety. And, we all know that there's baby blues and there's postpartum depression, but if you're only seeing a patient once at 6 weeks, what have we missed in the interim? And that really is the important part, is that we run the risk of allowing these patients to not know what's normal and what is normal, and to not have that opportunity to engage with them, to educate them, to support them for all the things that they could be going through. Next slide, please. And so this really is where the POWER program comes into place. It's really kind of that helping that transition from the hospital and delivery to the postpartum period, but doing it in a way that really supports our new parents. Next slide, please. So this is my all-time favorite slide. It actually wasn't made by me, but I love it. And so really, this is what the conceptual framework is for the POWER program. And I keep calling it POWER, and I apologize. POWER actually stands for Postpartum Wellness and Recovery. And so if you can kind of see, you transition from the hospital and then you kind of enter this kind of setup where the plan is really to focus on 3 things. So hypertensive disorders of pregnancy, maternal mental health, and gestational diabetes. I chose these because I felt that these were probably the 3 main disease entities out there that really I felt if we could have the greatest impact in terms of decreasing mental morbidity and mortality. And really, these programs are meant to, again, educate, support, offer resources, frequent follow-up for all of these patients. And then once they finish that postpartum period, whether it be 6 weeks or 1 year, to then transition them to primary care. Next slide, please. So as it was mentioned earlier, last October, we did begin the pilot for the hypertensive disorders of pregnancy. We decided to do that as our kind of year 1 rollout. Can you push next, please? There you go. So why is hypertensive disorders of pregnancy important? So again, 31.6% of deaths that occurred during delivery hospitalization had some kind of hypertensive disorder of pregnancy diagnosis documented. 1 in 7 delivery hospitalizations are affected by hypertensive disorders of pregnancy. HDP diagnosis documented in 1 in 3 deaths occurring during delivery hospitalization, and 1 in 5 delivery hospitalizations with hypertensive disorders of pregnancy were Black. Next, please. So what does the POWER plan do? First of all, we ensure that all of these patients are seen within the clinic within 7 days of discharge for an in-clinic blood pressure check. We have actually modified it a little bit, and for anyone who had severe hypertension or HELP, we try to get them into the clinic between 2 and 3 days. And so just to be sure, we are actually doing this right now. Collaborative care. So a lot of our patients may not actually be seen by us, but they may be transferred to us from a community birth center such as Rainier Valley. And so if that is the case, we want to be sure that we are in constant communication with their primary OB, because again, this is a very team-based approach. And I think that keeping everybody in the loop and making sure that everyone understands the plan is really important. We do a cardiology consultation based off of risk factors. So I have been very fortunate to have met Dr. Heidi Nice-Warner, who has a specific passion for heart health in pregnant and postpartum women and birthing individuals. Education and lifestyle modifications to improve future pregnancy and future health outcomes. One of the things that we should realize is that for anyone who has an HDP, they have an increased risk of developing it in their next pregnancies, but they also have a risk of developing cardiovascular disease in the future. And actually, heart disease is the #1 cause of death for women. And so if you can imagine, having the impact and being able to educate our patients on, hey, these are the things that you can do now so that you can be healthy in the future for both yourself and your family, I think is incredibly impactful. And I think that we can change, the future outcomes a lot of our patients. And then establishing appropriate follow-up care. So we want to ensure that once our patients are out of our care, that they are seeing a primary care doctor who actually also understands the importance of medical complications in pregnancy and how it can affect future health. And then again, a warm handoff. So that warm handoff meaning, this is what this patient has gone through. This is what we have done. This is what her cardiac consultation looks like. And this is what we would recommend in the future to keep this patient healthy. Next slide, please. Next slide again, please. So year 2 or phase 2, we want to then focus on maternal mental health. And again, this is kind of obviously this is what began the passion for postpartum program. 1 in 5 women will actually, in birthing individuals, experience perinatal mood disorders. And for untreated or undertreated perinatal mood and anxiety disorders, you can have things like poor breastfeeding rates, poor maternal-infant bonding, and lower infant immunization rates, increased risk of development of severe conditions, including psychosis, suicide, and homicide. And if we recall, perinatal mood and anxiety disorders are the #1 killer of women in the postpartum period. Next, please. So what does the POWER program hope to do? So we want to actually offer maternal mental health support for a full year. If a patient doesn't have the correct diagnosis, we would set up a perinatal psychiatry referral, either through a perinatal psychiatry or the UW program. Medication management, I've already been doing a lot of this, very comfortable doing it, and I would continue doing it. And then support groups that are led by group peer support trained individuals. So I currently have 1 labor and delivery nurse who's already trained, another one who would like to as well. And so really the hope is to offer support groups for our patients. At this point, Virginia Mason actually doesn't have support groups for postpartum patients. And so, again, meeting the patient where the patients are at. And so if we have the opportunity to really bring it, to the patient, then that would be the hope of the POWER program. Next slide, please. And then again, I'm just showing this again, just to kind of point out that, all those blue dots, it's 1 death related to mental health conditions. And again, it is the #1 killer of women in the postpartum period. Next slide, please. And next slide again, please. And so phase 3 or year 3 would be gestational diabetes. And so, why was gestational diabetes chosen? Again, for anyone who has gestational diabetes in the first pregnancy, they have a 13-fold increase. With the next pregnancies, they have a 7-fold increase in developing type 2 diabetes later in life, but also untreated or poorly treated type 2 diabetes increases risk of cardiovascular disease. So again, we're really trying to go back to what kind of future health issues can we manage now to keep our patients safe and healthy. Next slide, please. So the POWER plan, we want to ensure that all of our GDM patients actually get timely postpartum testing. We want to educate patients on the risk of diabetes development in the future and steps that they can take to mitigate their risk. We want to help patients, again, establish care with primary care, and then again, provide that warm handoff. So again, it's really about, you know, our work doesn't end just because they're done being pregnant. It actually continues, but we continue with primary care. Next slide, please. So this is the team right now, and actually we just hired a perinatal nurse navigator. So Dr. Nicewarner is a cardiologist, but we also hired Lacey Prasadmer, and I think she's here today. Her first official start date is September 25, and so her picture will soon be up here. But this is who we are. We also have a wonderful team behind us that includes Jen Fletcher, who was very nice to invite me today. Next slide, please. And so here really is our vision, is to actually create a POWER program standalone clinic. And as you can see, we really are thinking about everything from health to socioeconomic to, you know, whatever support they need, including lactation consultant, a social worker within the clinic, to assess patients with PMADs, physical therapy, dietitians to teach people how to eat correctly if they have gestational diabetes or if they're at risk for developing that or heart disease in the future. We're talking about perinatal community health workers. Again, you know, going back to health equity and, you know, meeting patients where they're at. Next slide, please. So obviously we have, you know, little stars where funding is needed, but, you know, we are so happy that we finally got a grant for the nurse navigator. And I really think that now that we have her, you know, really, this is where, you know, the fun and the hard work starts. Next slide, please. And next slide. So, you know, before, you know, ending everything, I just, you know, healthcare equity is really important to me. I think that honestly, before I did this work, I didn't understand between the difference between equity and equality. And so it kind of goes back to what I had mentioned before about meeting patients where they're at. And so, you know, it becomes important for us really to, you know, hopefully engage, you know, community healthcare workers to go to patients when they can't come to us, to assess, you know, needs. You know, can they buy a blood pressure cuff? Do they have a way of getting to us, and making sure that, you know, not only do we have the resources, but that we're actually able to get them to our patients or get our patients to those things. Again, you know, the POWER program in and of itself is really about, you know, social justice. It's about addressing, you know, the inherent racism that we have in our healthcare system and really trying to make a difference for everybody. Next slide, please. And so I also like to end with this. So this is another patient's voice. So I do a lot of chart auditing, and I actually found this note from a patient who developed severe hypertensive disorder in her pregnancy, and she's actually writing to her doctor. So I have urgent concerns that have yet to be addressed. I have yet to receive a call back to discuss test results from the last month. And I have tried to reach out multiple times to go over test results and next steps with Dr. X. Symptoms still exist and seem like they're progressing, and I'm desperate to move forward and find out what next steps I need to take. I am a mother with my 2 beautiful babies who need me, and I feel like if I have a serious condition, it would be beneficial to find out as soon as possible to see what my next step should be. Please, please, please have the doctor or someone reach out to me ASAP. I'm very worried and need reassurance and confirmation, please. You know, again, I read this, and every time I do, it saddens me, because here we have someone who is motivated and wanting to know and wanting to be educated and wanting to be empowered, and they're not getting that support. And so again, you know, having a program such as the POWER program really hopes to remove the kind of desperation that this poor mama is showing us. Next, please. And then actually one more slide, please. Sorry, one more. And so I just, it's always important for me, again, to show my gratitude for the people that have really helped me. And so I had mentioned earlier that there is a team behind this program that has been, couldn't do it really without them. And so I just wanted to call them out. Doug Baxter Jenkins, Jen Fletcher's here today, Catherine Klein, Dr. Nice Warner, and Jenny Tordy, who have been the cheerleaders and have just been the backbone really of this program. So any questions at all?
Thank you so much, Dr. Sapico. Feel free. I see, Johanna, your hand is raised, so we'll let you take off the questions. And if anyone would like to put a question in the chat, you can feel free to do that as well.
Hi, I'm Johanna Wolf. I work also with the Black Infant Health Program. Dr. Sapico, thank you so much for your presentation. It was really moving, actually. And so I'm just wondering, quickly, is there a timeline? Is the clinic happening? The vision that you have for this clinic? That's something I think we would be very, very interested in for our clients.
Yeah. So we received the grant just this past June, and we hired again Lacey, who was going to be our nurse navigator. And so we're starting the program here at Virginia Mason. As with all pilot programs, you almost have to prove that your usefulness first before they'll give you more money to do things. But you know, the dream for this really is to have a clinic like this for every hospital that has a birth center, because really, you know, I truly believe in teamwork and collaboration. This isn't just a Common Spirit thing or a Virginia Mason thing. This is a parent. This is a thing for parents. It's this thing for, you know, for really wanting to make an impact. And so, you know, once we are, you know, gathering more data and really proving, I mean, it kind of sounds stupid that I have to prove that we need this, but I think we all know how things roll. And so, you know, the hope is that, you know, as the program progresses and we gather data and we show that this needs to happen, that yes, we would definitely want to spread this out. I mean, if I could introduce this to all of the birth centers now, I would. You know, part of why we have the Women and Infant Clinical Institute backing us up is because we hope that, you know, with the data that we collect, that we could actually make this a national program for our Common Spirit hospitals. So it's coming, but slowly.
Thank you. We'll be keeping a watch out.
What sort of indicator? Oh, should I just go ahead and read? Is that okay if I just read the question?
Yeah, that's totally fine. And we just have a few more minutes to do Q&A. So anything we don't hit, you could answer in the chat if you'd like.
Perfect. So sort of indicators we'll be measuring. So we're actually measuring quite a bit. You know, we are measuring, we look at, so for hypertensive disorders of pregnancy, what we are looking at is, number one, we actually do a lot of demographic collection. We're looking at gestational age for when they presented. We're looking at starting BMI, ending BMI, at what gestational age did they develop hypertensive disorders of pregnancy, were requirements followed for delivery, what happened during delivery, did they have an IUGR baby, were they on magnesium sulfate, then upon discharge, you know, were they educated about just hypertensive disorders of pregnancy and what to expect, were they seen in a clinic, was an appointment made within 7 days of discharge? And then did they make that appointment? Were they able to see cardiology? What was the cardiology findings? Because she is testing for things like, you know, family history of heart disease. She looks for diabetes. She looks for dyslipidemias. She does an EKG, she does an echo. So we talk about whether or not there were any abnormal findings from that. And then we also look at whether or not they established with a primary care doctor. And so there's a lot of different things. And we also eventually want to include if they got pregnant again, how was that pregnancy managed? And, for as long as this program is running, we want to keep track of these patients until they're, 40s, 50s to see, because that's only when we're going to see, what the impact of what we're doing now, how it affects future health outcomes. Virginia Mason has many hospital locations. So I actually started at Virginia Mason, namely because that's where I am, and because our patient population is small. So it was doable because I was actually doing a lot of this work by myself. And so now that I have a nurse navigator, she's probably listening and thinking, oh my gosh, but there's a lot of work ahead of us in terms of really getting it out there. Our next probably hospital that we want to go to is St. Anne, because they have a very different patient population. And so that is that. Will this program work with maternity support services for Medicaid insured patients? Funny you should mention that. Lacey is a case manager for maternity support services. So, and she will be continuing to do that job along with this. And so I don't want to say I'm going to use her, but I'm going to use all of her data lists and all of her wonderful brain cells to do this. I'm telling you guys, I don't know if Lacey's still here, but she's a gold mine of information. And the fact that she works with maternity support services is the cherry on top.
I'm so sorry, Dr. Sapico.
No, that's okay.
We're over time, and I gave a couple of extra minutes, but please feel free to address the rest of the questions in the chat if you'd like, if you're able to stay on. Otherwise, we can send these questions to you to get them answered if you're okay with that as well. Thank you so much for sharing today.
Of course, it was my pleasure.
Mm-hmm.
Feel free to email me.
Definitely. All right. So up next, we've got Dr. Koboni Gondwe, who is an assistant professor in the Child, Family, and Population Health Nursing Department. She is originally from Malawi, where she trained as a nurse midwife, and her career spans over 15 years, with experiences both in Malawi and the US, and has shaped her research trajectory. Her program of research has focused on improving maternal and infant outcomes in Malawi and the US by studying the role of stress on adverse birth outcomes, maternal mental health, and how it relates to mother-infant interactions and adverse pregnancy outcomes such as preterm birth, the role of racism and discrimination, and other social determinants of health on predicting the risk for adverse pregnancy outcomes, especially for Black and Brown persons, and factors contributing to adverse pregnancy and infant outcomes among African immigrant women. She's currently studying the pathways in which life course stress, racial discrimination, nutrition security, neighborhood satisfaction, and social support contribute to pro-inflammatory profiles of pregnant and non-pregnant Black women in the United States. I will go ahead and pass it over to you, Dr. Godway. Thank you for being here today.
Thank you so much. So I'm originally from Malawi. I know people confuse Malawi to Mali. But I am from Malawi, to actually country in Southeast Africa. We don't consider us East Africa because we are more kind of on the southern part. But as she said, I am working at UW. I recently moved from University of Wisconsin, where I was teaching there, and then I started here. I think I've been here for a year. It's been an amazing time meeting people and getting to know people. And I had an opportunity to meet with Jax to talk about the research that I'm planning to do, and seeking out collaborators that are interested in similar research and clinics that we could do this kind of work. At the moment, we are preparing an R01 that is going to understand the relationships among stress, resilience, and social determinants of health. We're trying to see how all of these interplay and compare them in Black and white pregnant people. Next slide, please. So the reason why I got into this work is both by the observations that I've done since I moved to the US and my own personal experiences with access with healthcare system, but also in interactions with some of the pregnant people that I have talked to. And I think one of the biggest shocks that I had when I moved into the US, thinking about how advanced the healthcare system was to see the high mortality rates for like, it's the highest for high income countries. And so I was like interested in understanding why are these happening, and also noticing the racial disparities. I do come from a country that has a high mortality rate, but mostly it's because we do not have the resources and the staffing levels are very low. I remember when I worked in the maternity units, we would have like one midwife to over 50 women in a unit, and you're working by yourself, and you don't even have material resources to assist you to do your work. But I was like so surprised to also notice that the risk of dying for me as a Black person and pregnant here in the US was also very high, even with the advanced technology that we see. So in the research that I've done, and also the review of literature, I noted that racism and discrimination and systemic barriers are some of the factors that are contributing to the racial disparities that we see. And not only that, I felt like it's just like a cascade of events where one barrier or one social determinant of health ends up impacting all of the other social determinants of health. So that's why I also have issues surrounding food insecurity, housing instability, and also as I go further, I'll also be talking about access to healthcare, because talking to some of friends that I've talked to and understanding why they don't go to healthcare much earlier, the issues are very complex and they go beyond just health insurance, the issues surrounding their own personal lives and other determinants that impact them. In the research that we also did in the past few years, we also noticed that racism and discrimination across the lifespan, whether we looked at acute or chronic stress, they were elevated in Black pregnant people compared to white pregnant people. So being exposed to stress that comes with racism and discrimination over their life course does impact people, not just at the time that they experience it, but even in their future as well. So that's why I look at chronic stress. I try to understand how it relates to racism and social determinants of health, because all of these are linked to upregulation of pro-inflammatory profiles. And I use the inflammatory markers as biological markers for stress. Next slide, please. So this is just kind of a picture of an adaptation of a model that I use, is to look at how these social determinants of health are leading to stress, and even some of the stresses that people experience could also impact how they live and how they experience with the environment. And the outcomes of stress could impact one's mental health outcomes, but they could also directly impact the adverse pregnancy outcomes as well. Next slide, please. So one key element that I'm adding right now is the issue surrounding resilience. I have seen resilience being talked about as a mitigator of stress. And yes, it's a very important concept that we need to look at, and a concept that could really help us to understand. Next slide, please. Yeah, that would help us understand how we can manage stress. So resilience is the ability of one to adapt to adversity and stress. And it's being used in a lot of frameworks and in a lot of projects to understand how we can lower the impact of stress. However, in my work, I argue that resilience is both a response to trauma as much as it can also help one cope with stress. And it does place that responsibility on the person experiencing the stress to cope with it. Not that I'm saying that people shouldn't be resilient, but it's just the understanding that there are things that are also exposing people to the trauma, leading to them trying to be resilient against it. And we need to look at the systems and see how we can prevent trauma in the best way that we can, that exposure to traumatic events that would then help people to cope better with the stress, or at least prevent extreme stress exposures. So there are no biological measures that have been used to measure resilience, but there has been suggestions from animal studies. So we are trying to explore how this looks like in the human population. So we are assessing HOMA-1 and ATP-A12 to see how it relates to stress in humans, and then also how that is going to relate to stress outcomes as well. So this is going to actually be a longitudinal study. We'll be recruiting pregnant people in their first trimester and observing them throughout their pregnancy. And we do have a qualitative piece as well that interviews them to understand how they have, like how their pregnancy experiences were, their own perception of their own social determinants of health, and how it impacted their ability to cope with stress as well. Next slide, please. So I'm actually adapting a theoretical framework that was proposed at Duke University School of Nursing. So it's called a CLAF model of social determinants of health that tries to model stress, resilience, and how it affects birth health outcomes. And I am adapting it to pregnancy and trying to understand racism at different levels, and how that can, as I said, resilience is an outcome of trauma itself. So that how that relates to resilience, the stress experiences, and also understanding the relationship between resilience and stress itself, both at a biological level, but also perceived stress and perceived resilience, and how that relates to pregnancy outcomes. With a team that I'm on, initially we were only going to look at mental health outcomes, but we've decided to add in a bit more of adverse pregnancy outcomes to our project as well. Next slide, please. So as I said, the purpose of our study is to determine how social determinants of health associated with stress and resilience. We are going to model both the relationship between stress and resilience, and then at the same time see how social determinants of health fit into this framework. And we do have, as I said, a qualitative aim that looks at people's perception of their experiences as a whole, looking at social determinants of health, stress, and resilience. Next slide, please. And we are planning to actually recruit around 300 people. We will look at 150 in each group. The effect size, we need approximately 250, so that's 125 in each. But since we are following people longitudinally and with higher attrition rates, we are trying to kind of make sure that we at least have enough to align the analysis. So we are targeting about 300. Right now, we're aiming at UW Medicine as a site for recruitment. But as I said, we're also looking into other sites and people that would be interested in collaborating with us. Next slide, please. And how we're designing this is we're first of all going to recruit people for aim 1, which is a quantitative aim. And then after we do that, we recruit people from our aim 2, which is the qualitative aim. And people from the aim 2 will actually come from the 300. So we will try to recruit from the same group of people. And then finally, we are going to do an integration of the data to be able to interpret it, to understand how the qualitative data informs our quantitative data. And the reason we decided to use a mixed model was a mixed methods approach is because we wanted to give context to our data. Sometimes we have a lot of numbers, but we don't really understand the context in which the people shared those findings. So we really want to understand people's experiences and how that comes. Next slide, please. and these are some of the measures that some of the variables that we are planning to measure. As I said, we are looking at both biological and also subjective measures. So we'll measure both perceived and biological measures of stress and resilience. We'll also assess social determinants of health and maternal mental health. We're looking at initially depression, but we are adding more birth outcomes so that we can understand impact, not just at the mental health level, but also with other complications like hypertension disorders. I think that's just in summary what we are planning to do. I know I only had 15 minutes. I hope I did not go over. Thank you.
Thank you so much, Dr. Gondway. I do have a question. I don't know if you address this, but this is a statewide study, or are you only looking in certain parts of the state?
So and we are trying to do it like, I think when I talked to Jax the last time, I was trying to see if we could keep it in the, I'm not good with the regions, like in the Puget region.
Okay.
Yeah. So then eventually we can expand the bigger one when we have an intervention.
Sure, that makes sense. Thank you so much. If anyone has any questions, feel free to put those in the chat. Thank you again so much, Dr. Gondway, for coming and sharing about your study. I'm really excited to see the data that you're able to collect. And I think we would invite you to come and present them whenever the study is over. Before we get into our Black Infant Health program redesign presentation, we have a little bit of a surprise. So excited that the surprise is here in this meeting today. So real quick, I just want to give an introduction to our Champions for Children. That is through the Pierce County Early Childhood Network, which is now the newly structured collaborative that encompasses the work of Project Child Success and Help Me Grow Pierce County. So for those of you who have been around for a little while, you might know what the Champions for Children is, but just in case you don't, please, yes, you should be able to, Muriel, share your screen. Is it letting you? Okay, there we go. Just in case you're new and you don't know what Champions for Children is, one of the most treasured parts of our work with PCECN is celebrating the people and places that go above and beyond and supporting children and families through our annual Champions for Children Awards. This process begins in the spring when community members submit their nominations for people they think are deserving of this award. And these champions are narrowed down to just 5 people who are extremely special or organizations, and surprise awarded in a place that is meaningful to them. So we are super excited today to be here and to award one of our 2023 Champions for Children awardees. So please, Ms. Leah Johnson, this is all for you. So I'm going to pass it to Muriel, who is going to share a little bit more about your nomination, and just so thankful to have you.
Thanks, Heather. Let me go ahead and share the nomination, and just forewarning, I always get a little emotional reading these because they really are just so touching excerpts of what the great work we do. So every year we ask the community, do you know an individual, team, organization, or a business in Pierce County who has an extraordinary ability to make children and families feel encouraged, uplifted, and supported? So Ms. Leah Johnson's nomination included. She is always bringing awareness to the disproportionate outcomes that marginalized communities suffer from, and steps up to be a resource for those that she is affiliated with. She shares her experience and offers her expertise and wisdom to all who are interested. She never stops giving back to her community. She truly believes it takes a village, and she's willing to be part of that village and community. Leah continues to be a bright and shining light in the community as she gives of herself to support the growth and development of babies and children. She became and still is a volunteer health minister in the Black Infant Health program she founded, and she works with the local doula agency to support BIPOC birthing families, and she continues to support communities through facilitating community groups. I also want to make an open invitation to anyone else that would like to share anything about Miss Leah Johnson. You can do that either unmuting or through the chat, but definitely want to celebrate all the great work that she has done in our community. Yeah.
I had the honor of officially meeting Leah right before this meeting, but I have heard so many wonderful things about her since I've been working in this community for the past 4 years almost. And I just, as an outsider looking in, I just know that Leah is all of those things that were put in her nomination. And it's just so beautiful to get to witness people like Leah in our community doing the work that they do and just being amazing human beings. So thank you so much, Leah, for all of the things that you do for our community and for dedicating your life and your career to this work. It has not ever once gone unnoticed. And I hope that this helps kind of make you feel that that's the truth. So it looks like the chat is going off. So I'll let Muriel take over again, but I just wanted to share that. All right, so I'm actually going to take over for Muriel. So here is our Champions for Children event. What we like to do is we surprise each of our 5 candidates in meetings where they're around peers and people who are special to them. But then we also love to honor these folks at an event that we hold in person. So this year it's going to be on October 26th from 6 p.m. to 8 p.m. at Edison Square, which is on South Tacoma Way. Please feel free. I think the registration is open now, or it will be soon. So please keep an eye out for that registration. It's a really beautiful place for us to celebrate in person all of our 5 recipients. And we also like to do a surprise award at the event, but this year we're doing things a little bit different. So it'll be really fun to see how this goes this year, but would love to see you there and just continue celebrating, because that is what is fun to do. So thank you. All right.
Sorry about that, Taylor. I was having technical difficulties. But yes, I'm gonna drop the registration link for the actual event in the chat. It's completely free, family-friendly event to surprise and celebrate all of the champions here that we had for this year. And then Miss Leah, I will connect with you because we actually have an award certificate for you and would love to capture that. So congratulations again. And yes, I will drop the link in the chat for the event.
Yay! So congratulations again, Miss Leah. And we will get back on our regular meeting schedule. So Kendra, you can feel free to share the PowerPoint slides again. And we are going to now move over to our Black Infant Health Program redesign. So for this presentation, we have Emily Chandler and Pasha Abraham. Emily is the nurse supervisor for the Black Infant Health Program at the Tacoma Pierce County Health Department. She came to TPCHD from Comprehensive Life Resources, where she was the Director of Integrated Services and led the organization's work to build out a primary care clinic on site to integrate physical health care services with mental health care. Prior to this, she helped develop and lead the organization's mobile community intervention and response team, which provides direct community-based services to Pierce County residents who rely on emergency services for routine healthcare. Emily has been a leader in diversity, equity, and inclusion throughout her professional career and is driven by her passion for improving equity within the healthcare system. And Pasha Abraham is a community health worker in Black Infant Health. She has a bachelor's in social justice and psychology from Evergreen and is working towards her master's in public health right now. She's a yoga instructor and has taught yoga in schools and for youth in Pierce County's juvenile court system. And she has experience in community outreach, organizing, policy, and legislative processes, and creating equity strategies at the Washington Department of Health. Thank you both so much, and I'm going to pass it over to you now.
Thank you for those great intros, Taylor. I am Emily. And
I'm Pasha.
There you go. So we are going to be sharing about the Black Infant Health Program redesign, and we should have some time for some questions at the end, hopefully. So Black Infant Health Program provides Black and African American parents holistic, personalized pregnancy and parenting support from people who look like them. So through direct service, community engagement, advocacy, and policy change, Black Infant Health works to improve Black maternal and infant health in Pierce County. Next slide, please. So this is the Tacoma Pierce County Health Department's strategic plan for 2021 to 2023. And TPCHD is working to center anti-racism and trauma-informed care into all of our public health work. So as you can see by looking at the strategic initiatives in the green circles, Black Infant Health aligns with the latter four priorities of community behavioral health and well-being, healthy, resilient children and youth, health equity, and racial justice. Black Infant Health has been a hallmark of the department's strategy to center anti-racism and mitigate health disparities. And now, as TPCHD is planning a 6-year strategic plan from 2024 to 2029, Black Infant Health's redesign is being celebrated as an integral part of our internal growth, and it will continue to align with and be vital to the health department's priorities. Next slide. So the previous two presentations were a great primer for what we're going to be talking about. So this just to reiterate some of the information you heard earlier. Infant mortality is a benchmark of a society's overall health and a lead indicator of pregnancy and birth outcomes. So as you can see from this chart here, in Pierce County, Black infants die at more than twice the rate of their white counterparts and at a greater rate than what is observed in the state on average. Also in Washington, Black birthing people die at more than 2.5 times the rate of white birthing people. And these disparities persist even when controlling for social economic status. So Black college-educated women experience higher rates of infant mortality than white high school dropouts. And these disparities in birth outcomes directly reflect the serious health consequences of stress resulting from repeated exposure to racism, as well as direct impacts of racism from healthcare providers and racism embedded in the system. Next, please. So for a little historical context, in response to these disparities, the incredible Leah Johnson, who we just got to celebrate, she initiated the Black Infant Health Program in 2009, modeled after the California Black Infant Health Program. Initially, Black Infant Health worked with local Black churches to recruit Black health ministers to volunteer in the program to support Black and African American mothers from pregnancy through 1 year postpartum. These volunteer health ministers provided health education on topics like lactation, nutrition, infant health, safety, and also helped with resource connections and baby supplies and provided overall emotional support to individuals and families. So from single encounters to client referral linkage to ongoing support, we have supported over 500 families since. And while Black churches have been a cornerstone of the program, Black Infant Health has also gained strong community partnerships outside of the church. And in an effort to allow a little more inclusion, we are in the process of updating terminology to reflect our volunteers and clients who do not have involvement with the church. Historically, Black Infant Health has not had the capacity or the funding to really define the model and evaluate its impacts. And so now, with increased funding and more staffing capacity and the ability to pay our previously volunteer health ministers, we are able to focus on evaluating the effectiveness of the program while also expanding our reach. Next slide, please. So we have raised $1.3 million from private and public funders to pilot a program redesign for the next 3 years. As the only Black Infant Health program in Washington, we are seeking to develop and implement a replicable, community and evidence-informed parent support model that can effectively mitigate disparities and to scale it across the state. So to do this, we have been co-creating the program model with staff, contractors, and community partners, and investing in our infrastructure, staffing, and improving our data collection methods. Next slide. So some of the methods that we have used to define the program model so far include extensive literature reviews, listening sessions with Black Infant Health clients to understand strengths and needs of the program, community surveys to understand barriers and protective factors faced when accessing health services in Pierce County. Also learning from similar programs like the California Black Infant Health Program and Multnomah County's Healthy Birth Initiatives, and connecting with lots of different community partners. Next slide, please. So you can see here, these are some of the various organizations and people we've been meeting with as we prepare to launch a redesigned program. Next slide. So from doing all of this research and preparation, we have identified several frameworks and theories that have guided our work and will continue to guide programming. So the health impact pyramid shows how interventions focused solely on counseling and education require the greatest individual effort, but have the least population impact, meaning that Black Infant Health needs to focus on not only on individualized support, but also on policy advocacy at a system level to have the greatest impact in shifting the structures that perpetuate disparities. Next slide, please. So the socio-ecological model examines the individual, interpersonal, organizational, community, and policy levels of influence on individual health behaviors and health outcomes. It highlights that our behaviors both shape and are shaped by our social environments. So multi-level interventions are needed to shift health behavior, and health outcomes. Next slide, please. So as you can see from this diagram, we have envisioned the Black Infant Health Program model to be similar to the socio-ecological model, with direct service or the individual level in the middle being influenced by all other program components at different levels of intervention. In this way, our community advisory board will lead and influence our work at the policy level, which will be implemented and supported through our action collaborative at the community level. And additionally, our peer support group spaces will influence and enhance social connections at the interpersonal level. So by focusing on community engagement, advocacy, and policy change, we will ultimately have a larger impact on mitigating disparities. So now Pasha's going to talk a little bit more about each program component and give you some more details.
Thanks, Emily. So next slide, please. Thank you. So the direct service component of the program is a nurse-led community health worker model that provides support for the Black birthing community. As you can see on the screen, we offer two types of direct service, individual and group support. For individual support, our health ministers and community health workers provide monthly family-directed support to voluntarily enrolled clients through text, email, phone, and in-person contact from pregnancy until their child turns 1. And some of the services that community health workers and health ministers provide include full spectrum perinatal support, social emotional support, and mentorship. They also offer health education on numerous topics such as fetal development, maternal health, lactation, childbirth preparation, child health and development, family planning, attachment, and chronic disease prevention. They also link to culturally aligned behavioral health support, lactation, healthcare, spiritual support, and other social and material supports. Health ministers and community health workers also help promote self-efficacy, navigating the healthcare system and insurance, and supports clients to reach their economic and educational goals as well. To ensure clinical quality, a public health nurse will also provide postpartum visits for all Black Infant Health clients and be available for consult for emerging needs. In addition, a behavioral health specialist will also be on contract to support clients with unmet mental health needs. And lastly, through a partnership with Open Arms Perinatal Services, we are able to provide doula services for up to 10 low-income families each year. As far as group spaces, clients will be connected with other families going through similar transitions through our peer group support. For the first couple of years, we will offer these spaces exclusively to Black Infant Health clients, but in year 3, we plan to open them up to all Black birthing people in Pierce County. And on the screen, you'll see a picture of a cute baby with a graduation hat. This is from our recent Tiny Blessing celebration, where we honor the families with babies turning 1 who are graduating from the program. And just a quick shout out to Emily Chandler, who actually did a super cool DIY job on these graduation hats. And next slide, please. Okay, so the program's actually designed to support any birthing parent who identifies as Black or African American. They can join the program anytime between pregnancy and 1 year postpartum. 92% of currently enrolled clients use Medicaid, but there are no income requirements for eligibility. And I think I already said this, but people can enter the program anytime between pregnancy and 1 year postpartum. Next slide, please. So now I'll talk a little bit about community engagement. As Emily mentioned earlier, the program model is designed to mitigate disparities through interventions further upstream. So one of the ways that we do this is through community engagement. Black Infant Health focuses on community engagement by centering community voices and leveraging the influence, skills, and experiences of local organizations to improve maternal health policies, data systems, and service delivery systems. This also includes outreach to healthcare systems in an effort to address disparities in service delivery and offer education. Our team participates in various local events such as health fairs, community baby showers, and resource fairs. Recently, we partnered with Blackberry and Black Mamas to host an event for Black Breastfeeding Week. We provided free food, lactation consultations, family latch photos, and educational resources from local Black providers and vendors. And shout out to Marge, who's in one of these photos on the screen. It's one of our health ministers. Next slide, please. Okay, so within 1 year, we will convene the Action Collaborative, which will be comprised of community and faith-based partners, healthcare providers, service providers, and other stakeholders to collaborate, advocate, and share best practices. We will also develop a social safety net model to link Black birthing people to care and critical services that could be scaled to other communities where access to healthcare is limited. This helps increase community-based support for Black birthing people and ensure that Black African American clients served by these providers have access to social supports, such as the group peer supports facilitated by Black Infant Health. Next slide, please. We're currently recruiting for our community advisory board. The board will help develop and evaluate the program and project strategies to ensure alignment with Black Infant Health goals and objectives. In addition, the board will inform Black Infant Health community engagement and action collaborative strategies. Members will participate in a 2-hour virtual meeting about every other month, and they will be compensated for their time. And I think Emily just popped in the link to our community advisory board flyer. Applications close at 11:55 p.m. on September 25th. So if you or someone you know are interested, please apply and feel free to share this opportunity far and wide. We are prioritizing people who live or work in Pierce County and people who are Black or African American. But we are happy to answer any questions you have about the Community Advisory Board, so please don't hesitate to reach out. Next slide, please. And this is just an overview of our pilot timeline. Over the last few months, we've been working on co-creating the model with our partners and building an evaluation plan so that by October 1, we can implement the pilot of the new model. During this time, we will also launch the Community Advisory Board and Action Collaborative, which we just discussed. And in year 2, we'll focus on expanding the model to other counties and hone in on our policy and advocacy recommendations determined by the Community Advisory Board. In year 3, we're focusing on analyzing and evaluating program data. And by the end of year 3, we're hoping to fundraise for sustainability and be working with other community partners to adopt the model. Next slide, please. And this is just a brief overview of the structure of the Black Infant Health team. At the top, you'll see the Community Advisory Board, which informs the work of our program. And the program is led by a nurse supervisor. Our team is comprised of a community engagement coordinator, health minister coordinator, public health nurses, and community health workers. Currently, we have 6 health ministers, and we're recruiting for culturally aligned behavioral health specialists. Both our health ministers and behavioral health specialists are contracted positions, which is why they're shown in blue. Next slide, please. Okay, so on this slide, we're showing just our short and long-term goals. With this new program model, we hope to have short and long-term impacts that will lead to improved health outcomes for Black families. Short term, we hope to have an impact on self-efficacy associated with parenting and navigating and advocating for family needs in a healthcare setting. Long term, we hope to have an impact in reducing maternal and infant mortality rates and improving health outcomes for Black families. We are currently working on developing evaluation methods to measure for these impacts. Next slide, please. And we're definitely missing some folks here, but this is the most up-to-date picture of our team at a Tiny Blessing celebration in May. And next slide, please. Perfect. And that concludes our presentation for today. Thank you so much for your time, and we're happy to answer any questions that you have about our work to keep families healthy and safe. Thank you.
Thank you both so much. Just really great work that you've got going on, and I'm really excited to see all of it as it unfolds. So we are 1 minute away from 1:30. So if there are any questions about Black Infant Health, please make sure you jot down Emily or Pasha's email information. They may have shared it in the chat earlier. I'm not sure.
I'm going to share my email right now as well.
Okay, perfect. And it looks like Emily also shared the information for the BIH webpage. So thank you both so much. Thank you to Dr. Gondway and Dr. Sapico, and congratulations and surprise to Leah Johnson. Our next meeting will be on December 11th. Please make sure to complete our post-meeting survey. And just an FYI to all of you, our Education Day is coming up in October. And so please be on the lookout for a save the date and registration information on that coming to your inboxes soon. Thank you all so much for being here today. And we look forward to seeing you in December.